Hi, I'm Dr. Jack West, medical oncologist at Swedish Cancer Institute in Seattle, Washington. One of the puzzling situations you might face in the cancer clinic today is someone who presents with a rare variant of a more common type of driver mutation. And a case that really illustrates this question for me is someone I just saw again in my cancer clinic who presented in mid-2012 with an advanced metastatic lung adenocarcinoma. She's a never-smoking Asian woman in her mid-40s, and at the time of her diagnosis, I sent off biopsy of her tumor tissue for molecular markers and found that she actually has an EGFR mutation. And that usually helps clarify exactly how to proceed, because the patients who have one of the more common so-called activating mutations are very likely to have a profound and often typically prolonged response to an oral EGFR inhibitor like Tarceva, also known as erlotinib, or in other parts of the world, Iressa, also known as gefitinib. Now, the challenge was that her particular mutation is in exon 20, which is a part of the EGFR gene that is relatively rare to find a mutation on, and these mutations are so uncommon that we really don't know what to expect. Should we treat them as if the patient has one of the more common mutations that tends to be associated with a very good response to these oral EGFR inhibitors? Or should we treat them like somebody who doesn't have an EGFR mutation at all and pursue chemotherapy as the first approach? At the time that she was first diagnosed and we found this mutation, there was really no good answer to that question, and I talked with her about the options, and she ultimately decided that with our discussion she would prefer to start with Tarceva and see how she does, with the understanding that if she were to experience a significant worsening of her situation, we would switch very promptly to chemotherapy. As it turned out, she didn't have a dramatic response, but she had perhaps a minor one and continued to feel generally well, and her scans didn't really show any convincing evidence of progression for about 6 months or so, and even now is only showing very slow, minor evidence of progression. But what can we say? Have we learned anything new about how patients with an exon 20 mutation might do? Well, there's a little bit of information that has actually just come out in a publication in the Journal of Thoracic Oncology. It was published and written by a colleague of mine, Dr. Jeffrey Oxnard, coming out of Dana-Farber Cancer Institute and Brigham and Women's Hospital. And he and colleagues there reviewed a database of what they could find on patients who had various types of EGFR mutations and found 20 patients who had an exon 20 mutation, and they looked at whether these patients tended to behave more like the patients who have one of the more common exon 19 or exon 20 mutations that tend to be associated with a very good response to these oral EGFR inhibitors, or whether they responded more like patients who don't have an EGFR mutation at all. What they found was that patients with an exon 20 mutation did not actually have dramatic responses to these oral inhibitors. In fact, none of the handful of patients who they had information on had had a particularly strong response, although some did have at least stable disease for several months at a time, similar to my patient. They also found that the survival of these patients was not as dramatically long as the patients who have one of these activating mutations in EGFR. And in those patients with the activating mutations, they saw a survival that was well into the range of several years. And it was about half of that in the patients who did not have one of the common EGFR mutations. Those with an exon 20 mutation, though there's certainly variability, just did not have that dramatic of a response or benefit. And the overall survival was really comparable to that seen in the patients who don't have an EGFR mutation at all. Now, one thing that I would like to highlight is that this is still based on a very small number of patients, and it may matter very greatly what specific mutation on exon 20 we're talking about. In other words, even the small group of patients with an exon 20 mutation may be so broad that there can be a lot of variability in one person's exon 20 mutation versus another person's exon 20 mutation. And because of this, I think, especially when we're talking about small numbers of patients overall, it's hard to make any big generalizations. These are rare patient situations, and I think it is still important to try to approach each patient as an individual. And in this situation, I don't think it was a wrong decision for us to decide together to start with the EGFR inhibitor. She's still tolerating it well and hasn't demonstrated clear progression of her disease in any clinically meaningful way. So I don't think it was a mistake, but we are all still learning about how best to proceed with these unusual settings. Take care. I hope that's helpful.